All right, this is going to be a quick video on COVID-19. A little bit more than basic mechanical ventilation for more seasoned operators and those that have gone through these prerequisite videos. Dr. Gross, of course, has done a very comprehensive basic mechanical ventilation lecture, link provided here. Some more basic videos that went into ARDS listed here, both by myself and Dr. Jameson. For anesthesiologists, the airway practice is nothing new to you. In fact, you pretty much helped us develop this, but I think it's worthwhile to review that airway code and code blues, especially the second half that goes into how we've asked the nurses on the different units to prepare and run a code so that you're familiar with what the ancillary staff are doing during airway codes and code blues. And finally, I shared this link with many of you last week, but about 8-9 days ago, a very nice review on some of the key management issues with high compliance, low elastance COVID-19 patients from the European Society of Critical Care Medicine. What that video really went into, and we'll get into this in the meat of this discussion, is that there seems to be more of a low elastance. Initial reports of severe ARDS were probably a little bit overstated, or at least we haven't seen it as frequently. And hence the hypoxemia that we see in these patients is not a diffuse process, but more focal infiltrates with significant associated shunt. There may be additional issues that lead to hypoxemia, including dead space from small vessel thrombosis that's been postulated, and some data and radiographic evidence for further dead space and VQ mismatching with small airways being plugged with tenacious thick mucus. Classically, when we see patients with severe illness from infection that come with high oxygen requirements, we are getting ARDS patients. This is in the pre-COVID era and still within the COVID era for non-COVID patients. These patients with their diffuse edema usually have low compliance, high elastance, along with their diffuse edema. These patients are often treated with higher PEEP, and this is to keep airways and to overcome the surfactant dysfunction that leads to alveolar collapse. What we're seeing, though, in this pandemic is that there is a large group of patients that have low elastance, some of the way high compliance. And because of that, PEEP tends to overdistend small airways and alveoli, leading to worsening VQ and hypoxemia that worsens. And that overdistension at the capillary vascular bed leads to a drop in left-sided preload that leads to ongoing shock. So during this talk, we'll get to how to manage these patients, but I'm going to leave that for a little bit later. I wanted to just do some front matter first so that basics of ICU management are discussed, as most of you are facile with the ventilator, but this is a different thing to be in the ICU with our ventilators, and I'm going to focus on initial settings and how to set up our ventilators and some of the practices that we have in the ICU. I'll start with interactions with the RT in the ICU, since they don't exist in the OR. It's usually the RTs that are making all the changes on the ventilator. During this pandemic, to minimize the amount of entries into the room, oftentimes if we find someone overdistended, we may leave someone on lower PEEP, and at least up until now, though I can't speak for all the RT groups, as long as we communicate and place orders for changing the PEEP while we're in the room, the RTs are more than happy to have us do it because it avoids entering and potentially risking contamination to person and use of PPE. That being said, it's very essential that any changes that you're making on the ventilator are accepted completely. What I mean by that is, as I'll show you on the hands-on portion separately, oftentimes that final accept isn't done and the patient may remain on pressure support um, and, and have an inadequate ventilation, and you think that they've changed them to volume control. So be very careful that as you leave the room that the patient is on the ventilation and the settings that you want. And then communicate changes to the nurse and the RT and place the order so that we can make sure that everyone is comfortable with ventilator management. One thing that we're doing is also minimizing the use of ABGs, assuming that we may have a big need for labs and ABGs down the road, and have gone to following end-tidal CO2 and saturations more frequently. These are things that is part and parcel of anesthesia care in the OR, so I think going into detail with this is unneeded. We're targeting saturations on the lower side of 90s, even into the high 80s. But the end-tidal CO2 monitors, of course, changes can signal pulmonary vascular events, pulmonary embolism, and changes and differences between end-tidal CO2 and arterial blood gas values for carbon dioxide can help with finding ideal PEEP and minimizing dead space. Another thing that is different is our use of high-flow nasal cannula during this pandemic. We are using it to avoid intubation. This is a device that over the last 5 years has grown in its ability and documented efficacy in minimizing intubation, mitigating respiratory failure, and even post-extubation respiratory failure. One thing that was new to me, and this is a slide stolen from a meeting involving Eric Kreiner, respiratory therapist over there, is the fact that despite the higher flow rate, that patients actually disperse air particles to a shorter distance. It shouldn't be so much of a surprise since the flow is directed inward and therefore probably counteracting the propulsive forces of aerosol dispersion in, for an infective etiology. That being said, those patients on high-flow nasal cannula have been shown to have 0.5 meter greater cough distance, which is why the manufacturer for high-flow devices recommends a surgical mask over the nasal cannula. What we've been doing routinely is using a tight-fitting non-rebreather for both cough mitigation and also during entrainment of ambient air, that at least that ambient air is oxygen rich. So initial settings, I'm going to kind of jump to this and discuss it again when we get into the servo-u in the next section, but a lot of things are different during this pandemic, and one of them is that all of these patients are being intubated with rapid sequence intubation, usually always paresed, and some of our routine settings that we do after intubations classically are inadequate and can lead to hypercapnic acidosis. Routinely, respiratory rates in the past have been lower. I find that sometimes after paresis that this respiratory rate of 16 is the default setting. Another thing that we don't often focus on is the inspiratory time, and that's modulated by two values that are set on the ventilator. One is the set inspiratory time, and if you're in volume control, oftentimes a pause of 0.2 or 0.3 seconds is added to that inspiratory time, leading to a total inspiratory time north of 1 second, maybe even approaching 1.2, 1.3 seconds. And in patients that are tachypnic, especially after paresis wears off or if the respiratory rate is set this high, that leads to very short expiratory times and even inverted I to E ratios. I'll show you some of the consequence of that in a second. So we have discussed with the respiratory therapy to change the default I time to something that's a little bit shorter, 0.5 to 0.7. This, of course, will increase the inspiratory flow rate to deliver the same tidal volume, and to shorten the pause time from 0.2, 0.3 to half that, 0.1 to 0.15. If you even want to pause so that you can be monitoring plateaus from breath to breath and minimize entry into the room. But it's up to you, and you can also keep the pause off. If you choose PRVC, there is no pause in that, so the total I time of something such as 0.7, 0.6 seconds can be set. PRVC, as we'll get into in a little bit, is a mode that I'm using more frequently than in profound hypoxemic respiratory failure in the pre-COVID era. One of the reasons we're using it is that its more comfortable pattern of inspiratory breath delivery may lead to lower agitation and therefore lower sedation requirements than that quick, constant volume control flow. And I'll show you some images of these flow patterns. Shown here is a volume control mode. Shown in the green is the flow pattern with that square flow and an end inspiratory pause shown here. In this mode, the patient is breathing at a rate of 29, and given a very significantly long total I time, the I time is much longer than the E time, and the I to E ratio in this case is inverted. What you can see is a very high pressures. Both the peak and the plateau are elevated. There's persistent end expiratory flow, which leads to auto-peeping that contribute to these high pressures. By simply reducing the I time, which does mean higher flow, and reducing both the I time in terms of the set I time and that long protracted pause, you can see that there was a 1.2 second I time set that you can, and if you drop it to half that, you can drastically reduce the auto peep and the plateau pressure. You may notice that the peak pressure actually went up, and this is an unexpected because by lowering the inspiratory time for the same delivered tidal volume, that means that there's a higher flow rate required to get that breath in quicker. Therefore, the resultant airway resistive pressure related to flow will go up. You can see that here with that higher peak to plateau or resistive pressure compared with the resistive pressure before. And that again is related to that higher flow rate. This resistive pressure is felt, of course, in the upper airways and is less likely to contribute to frank barotrauma, except in cases of upper airway injury, upper airway anastomosis after lung resection or transplant. And really we focus on the plateau pressure, and having a lower plateau pressure by a considerable amount due to lower auto-peeping values is more likely to preserve lung integrity and avoid barotrauma. So I know I started off with those settings and I'll come back to those settings, but just to step back and talk about the different modes. This volume control mode or assist control is the common mode that we often use in severe hypoxemic respiratory failure, but we're using, as I said, a lot more PRVC. Might not be a mode that you have used frequently in the OR. Pressure support ventilation is a mode that we use as we get patients ready for spontaneous breathing and liberation from the ventilator. And we're not really using pressure control. In this ventilator, it's really not that much different than PRVC when deeply sedated. So differences between volume control and pressure regulated volume control. And I'll show you some waveforms that show this as well in a second. They are essentially the same in that they are both looking to deliver a tidal volume. The primary directive, though, in PRVC is to avoid going over a certain pressure guided by the pressure alarm setting. PRVC does this by modulating the flow rate during the breath, so the flow actually will start to decrease during the breath, therefore decreasing the consequent resistive pressure associated with that flow, so that the sum pressure from both elastic and resistive forces are truncated to limit the pressure. The primary directive, again, in this mode is to minimize that pressure alarm, pressure target. And the tidal volume is a secondary issue. In patients with very tight, highly elastic, low compliance lungs, or having a significant airways resistive issue, those pressure limits will be reached earlier despite truncated flow, and the volume may be sacrificed. Conversely, if the patient is making negative efforts, negative pressure, then the patient can get quite a large volume and not reach those positive pressure limits, as the sum of the patient's negative pressure will decrease the total pressure that the ventilator sees. So use of volume control guarantees that volume. We can set that pause after every breath, and we can assess mechanics accurately and from breath to breath, and we can see changes from even outside of the room if we set that pause with every breath. And I'll show you some images of that shortly. The problem with this is that it's a very unnatural mode of breathing, a square, rapid, constant inspiratory flow, truncated suddenly, and then expiratory flow to be occurring passively. Is that inspiratory flow being so abrupt can give patients a sense of dysynchrony and often require sedation to avoid that dysynchrony. As mentioned, the pressure limiting effect of PRVC avoids alarms, minimizes the RT's need to go into the room. But if the patient is breathing spontaneously, they can get very large volumes. Therefore, avoid being lung protective when you want certain patients to be lung protective, or in patients with severe asthma when you want to kind of minimize their inspiratory volume so they have time to exhale. It may not always do that in this mode. So going back, we've already kind of talked about this. I just purposely wanted to discuss this again. Given that these patients often after the paresis is over will have high respiratory rates spontaneously, or need high respiratory rates to adequately ventilate, we should avoid long inspiratory times. This issue with inspiratory times is compounded further in that volume control mode if there's a pause that's left that's especially long, and in that case, again, the pause time should be truncated. Trying to target the total inspiratory time to 0.7 seconds or less usually leads to flow rates that are in the 48 to 60 range, and avoids having inverse ratio in tachypnic patients. The other thing that's often set is the tidal volume in these modes. We are aiming to be lung protective, and lung protective ventilation by definition is 6 cc's per kilogram ideal body weight, which is determined by height and sex. Most males in a normal height range are not even close to 500 cc's at 6 cc's per kilogram ideal body weight. And similarly, there's an error here still, I apologize, but this should be 340 to 380 for most. So it's in the mid 300s for most women. In patients that, and this is really meant that these type of lung protective ventilations are really meant for those with that ARDS. And as I mentioned, a lot of patients have this low elastance, non-ARDS type of feature, and aiming for slightly higher tidal volumes can avoid and match some of the um, inspiratory request of the patient, and therefore decrease sedation and avoid huge negative pressure swings that may be contributing to worsening edema. So going up to 8 cc's in those patients that are more compliant, lower elastance is reasonable. This is a suggestion that's been made by the European Respiratory Society. In those patients with severe ARDS and low compliance, though, the goal should be to still stick to 6 cc's or less, aim plateaus for 30 centimeters of water or less, and the driving pressure, which is the difference between the plateau pressure measured and the PEEP, aiming that for 14 centimeters or less. And I'll show you some driving pressures. So measuring compliance does require doing that inspiratory hold and measuring a plateau pressure, and therefore measuring the driving pressure, the difference between the plateau and the PEEP. This can be done along the left side of the monitor. You'll see the maneuvers tab, and if you press on the maneuvers tab, this will pop up, and if you press and hold the inspiratory pause, you will get a plateau on this breath. And that will be registered and shown in that plateau box on the right, not shown on the screen. This plateau box here. This plateau can also be measured from breath to breath. In this case, again, this is a pretty high total I time, and you can see that this patient is close to one-to-one breathing, inspiration to expiration, and that's because of this long pause. But this pause can be shortened, and that plateau can be measured with every breath and not using the maneuvers tab. So again, in order to measure the plateau in PRVC, since there is no end inspiratory pause dialed in, you can hold that that maneuver button and inspiratory hold, and you'll get a plateau. But since the tidal volume is not guaranteed, there may be variation in tidal volume from breath to breath. There may not be, especially if the patient is adequately sedate, but that change in tidal volume will affect the consequent plateau. In volume control, again, either setting a inspiratory pause with the end of each breath, and it can be as short as 0.1 to 0.2 seconds. And this is actually what they used in the original 2000 ARDSNet study to measure plateaus routinely during low tidal volume lung protective ventilation. Or you can do that longer plateau with that inspiratory hold maneuver, and once in a while it's worthwhile to do that and confirm that that is an accurate plateau with a short pause. Compliance is the volume, the tidal volume, over that driving pressure, that plateau minus the PEEP. The ventilator will often report dynamic compliance, which is a little bit different, although I am not convinced that it's reporting a dynamic compliance. Often it does look like what it's reporting is the static compliance if there's a pause dialed in. The driving pressure, as mentioned, is that denominator of that compliance equation. It's that plateau minus the PEEP. Hence, being on the denominator, a lower driving pressure means a higher compliance. Pressure control, I actually haven't shown pressure control. This is a PRVC mode here. And you can see how the pressure kind of gets truncated and how flow is modulated during the breath to assure that the pressure target is reached and not exceeded. In this case, the tidal volume delivered isn't exactly the tidal volume that's requested, but this is due to the pressure limit that was set. But pressure control would look identical to this. I would just take that driving pressure of 17 over that PEEP of 5 to reach this peak pressure, or this pressure at this top pressure here. Since it isn't very different than PRVC, we very rarely use pressure control in our ICUs. Pressure support ventilation, when the patient can breathe spontaneously, is a mode that we use very frequently, especially if the patient is progressing to weaning or if they're awake and comfortable on the ventilator and just need an airway, and if they don't have major acute hypoxemic or resistive issues. More on weaning later and to follow this presentation. So getting into the meat of things, to go back to this low elastance, high elastance issue, and to reiterate some of those things that we've seen and then shown in that European review that was listed at the front. This is what we've kind of written in the cheat sheet that will also be available for you come Monday, which is that not all patients with COVID that have acute and profound hypoxemia have ARDS, nor should they be treated as ARDS. We have seen that these patients have high compliance, low elastance when measured, and that's very different than ARDS and should be managed differently. If they have more of an asthma or COPD exacerbation, then that's one of the reasons they would have a low elastance, high compliance phenotype. Or what we're seeing more frequently are these focal or multifocal pneumonias with significant shunt. And that shunt doesn't necessarily improve with PEEP. And protocols intended for ARDS may lead to harm, and I'll show you that as well. There have been cases of ARDS, both mild and severe, as defined by PF ratio. They're more likely to be high elastance, low compliance. And we do have a management of ARDS that's also outlined in the cheat sheet. But our initial exuberance and thought that we would be seeing a lot of ARDS has not been matched by our clinical experience. As shown in this case, this is a patient that's doing quite well actually, but had a pretty rocky road initially in the middle of March, had some fevers and chills, was given a Z-Pack, continued to worsen so that by day 7, 8 of his illness came to the ED tachypnic, hypoxemic on room air, was found to be COVID-19 positive, as was his wife. When he was ambulating, desaturated, got on a significant amount of nasal oxygen, went to the ICU, and despite high flow nasal cannula, which we were truncating the flows back several weeks ago, and we probably could have gone up on the flow rate and maybe avoided intubation. So I really do encourage going up to 40, 60 liters of flow before deciding intubation. But he got intubated in line. This was his admission chest x-ray with some focal patchy disease, especially prominent on that left side. Now a little bit more dense by the time that he got more hypoxemic. You can imagine that this dense consolidation shunting a lot of blood to that area and causing this profound hypoxemia. And then post-intubation, better aerated with PEEP and a good tidal volume, but significant patchy infiltrates, but large areas of fairly preserved lung. And this is someone that would be predicted to have a lower elastance, higher compliance phenotype. The pictures here are a bit blurry because they're taken with a phone through a bag to preserve cleanliness of the phone camera. Shown here, tidal volume of 400, a rate of 26, and initial FiO2 of 1, but we were able to drop this to 80 while assessing mechanics. The initial PEEP and plateau, because of the ARDSNet approach initially, is a significant PEEP of 14 and a plateau that seems lung protective. It's below 30 centimeters, it's 27. Patient's a little bit relatively hypotensive and tachycardic. By just going up on the PEEP, you can see that from 14 to 18, that the plateau is increased to 35 from what it was before, which was 27. Now the driving pressure has increased. I'll show you a table that documents the driving pressures in the PEEPs and the plateaus. Blood pressure drops. This is a higher driving pressure than before. And this suggests that in that low elastance, high compliance, that adding that extra PEEP has led to distending and stretching and causing some tension, over distension in that lung that could be contributing to this hypotension. Confirming this, dropping the PEEP from that initial setting of 14 down to 10 drops the driving pressure from 13 to 20. The plateau is now 20, and the patient's hemodynamically a little bit restored. This leads to what is the best choice of PEEP, especially with patients that have this low elastance, high compliance phenotype. And should we be using tables? And I'll show you a table that we typically use for ARDS, or one of these two separate tables: a lower PEEP strategy compared to the FiO2, and one that's a little bit more aggressive in ramping up the PEEP so that PEEP gets up to significant numbers, even in modest increases in FiO2. That higher PEEP table is often used for patients with more severe ARDS, determined by PF ratios below 150. And again, our initial thought that this was an ARDS process has come from reports from China, but even recent reports from Italy showed that median initial PEEPs were 14, such as in the gentleman that I showed you on his initial setting. They did report lower mortality than that seen in China, but in truth, I don't think it was a very complete mortality estimate, as many of these patients were still actively in the ICU without a clear disposition determined at the time of the publishment of this article in JAMA last week. So these are median PEEPs and FiO2s from Lombardy region of Italy. You can see another recent quick report of initial ventilator settings in the Seattle area, where they did report a mortality north of 50%, shows similar likely higher PEEPs. The PEEPs weren't actually reported, but based on the plateau and the driving pressures, you could imagine the PEEPs in that 12 to 14 range for many of these patients initially. Last week, at the time that this presentation was first put together, Dr. Santi and myself were in the ICU, and on a quick survey of all of the ventilated COVID patients at that time, and granted they're not day one values like the ones reported in the Seattle and Lombardy study, the median PEEP was 6.5 by the end of the day. With an additional patient on the vent, it had popped up to 8, and a median FiO2 of 0.5. Going back to the patient that I just described, this is his data in a tabular format, starting off with a PEEP of 14 and a plateau of 27, going up and down on the PEEP, shows that the driving pressures were really minimal at lower PEEPs, suggesting that this patient does have a good compliance, a low compliance, high elastance. For a tidal volume of 400, this driving pressure of 10, that means a compliance of 40. We're using a cutoff of 30 or 35 to define the border between low and high compliance. And we left the PEEP in this lower range. And if the patient had remained on the ARDSNet protocol, a number of consequences could happen. Another way of setting PEEP is to do a slow PV curve. I'm not really going into details on how this is done, but to accurately get a pressure volume curve and see where the so-called lower infection point is can be done with a little bit of vet wrangling, can be shown on a case-by-case basis. And we often set the PEEP a couple centimeters above that predicted lower inflection point. And in this case also would predict a ideal PEEP setting in the 8 to 10 range. So what would happen if we use the ARDSNet protocol in this patient? We'd end up with either PEEPs in that 14 range or in that 20 range. And when you have this L elastance high compliance phenotype, you can, and even in the H phenotype, if you set your PEEP too high, you can get consequent hypotension from a drop in left-sided preload. It's often responded to with fluids, although you could use vasoactive drugs, but if you give fluids and the patient is inflamed and leaky, that can lead to more frank ARDS. And that leads to more PEEP, and that PEEP can lead to more hypotension, the more PEEP coming from having worsening hypoxemia as the fluids cause ARDS, and this vicious cycle continues and continues. And as that lung gets over-distended and has open-close injury, all those things mentioned in the previous ARDS PowerPoints, that can lead to systemic dysfunction of both kidneys, GI tract, brain, and maybe contributing, this is just hypothesis, to some of the high mortality seen, especially when using higher PEEP strategies. Key thing is to avoid over distending those that have a low elastance phenotype. Going back to our patient, easily over distends with PEEPs of 10 or more. We left him at 8 to 5. This was confirmed a couple of different ways. He did get hemodynamically worse when he was on higher PEEP. He was with a restrictive fluid protocol and even a little bit of inhaled epoprostenol, which I'll probably discuss in a separate presentation. He was stabilized to the point that he was safe enough to extubate the following week, and is actually doing very well now, 5 days after extubation. And glad to report that this gentleman has been stepped out of our ICU to a floor bed, potentially on the road to recovery. More from our cheat sheet. Again, the emphasis in that all patients with COVID and acute hypoxemic respiratory failure do not have ARDS. To guide this, again, we're using compliances, again, 30, 35. I think the final cheat sheet will probably say 35. You can calculate some things such as the Murray lung injury score. It came to my attention from one of our fellows that Dr. Murray passed away at the end of March, did some pivotal work in defining ARDS. He died of COVID-19. But really, without even making measurements, the prediction of whether or not someone has a high compliance, low elastance phenotype can be made just on the chest imaging when you have focal disease in large areas of normal lung. So there's a lot of ways that we can set PEEP. You can decide based on imaging that this is someone that maybe you're going to use lower PEEP on. You can use those PEEP tables, but again, if they don't have ARDS, this PEEP table can cause harm in this case. You can aim for the lowest driving pressure, determining where that upper inflection point above which distension happens occurs. And again, the easiest way to identify that is as you go up in PEEP, if your driving pressure increases, that means you're losing lung compliance, suggesting over distension. You can also confirm where that lower inflection point is by doing a slow PV curve, as shown at least on one slide. And there are other methods that involve labs, including end-tidal CO2, mixed venous saturation, devices such as impedance plethysmography, or if this is a laborious task, assigning a specific group of us to go around and do vent rounds. So an ideal method when thinking about all this would be one that's easy and fast, and I'll emphasize the easy, and is accurate and limits resources and manpower, minimizes entry into the room, and isn't harmful. When you go back to all the different methods, you can arbitrarily, of course, decide to use a lower PEEP, but this may not always be accurate. Conversely, using PEEP tables that are intended for ARDS may not be accurate and over distend the lung and put the patient at risk for having too much PEEP. Again, titrating based on going up and down on PEEP and calculating that lowest driving pressure. It isn't easy right off the bat, but and there's some training required, but it's not difficult. That slow PV curve is definitely not easy. It requires a lot of vent wrangling. It has been validated in small looks, but has some significant risk, and especially since you're dropping the PEEP and changing the tidal volume and the flow rate transiently, it's not one that I would recommend for routine use unless you feel very comfortable and have experience with doing this. The lowest delta between the arterial and the end-tidal CO2 can be used to guesstimate the point where you have the lowest dead space. Similar things can be done with mixed venous saturations. We don't have impedance plethysmography devices, so the best thing right now is probably to choose something like the that driving pressure method. but also identify people that are likely to have that L phenotype and start with a low PEEP based on imaging, and use more oxygen and think about other therapies such as paresis, turning, and maybe epoprostenol. So I'm going to end this shortly. I just wanted to put a little bit about proning and weaning and discuss this more in the next discussion. There is a cheat sheet and an order set for proning. Proning is really being done for those people that have severe ARDS, but there may be a role with those that have more focal disease and have a lower lung elastance, high compliance with focal pneumonia. More to come on this. And then finally, a little bit more on weaning. When patients get down to an FiO2 of 0.5 and are at a PEEP of 8 or less, we can put them on these weaning protocols. There's an order set. The patient typically has to be off pressors, but many times, if communicated, the respiratory therapist will do the weaning protocol on minimal pressors. The patients will often put the patients on 5 of pressure support and 5 of PEEP, which actually is a significant amount of support, especially for those patients deconditioned and on the vent for a long period of time. Looking at a number of parameters, including the respiratory rate and the tidal volume, they will be deemed as passing the SBT, and then an assessment should be made for safety to extubate the patient. Again, this support of 5 of pressure support over 5 of PEEP in those patients that are weak and deconditioned, all they need is that little extra support, and you may consider doing a more rigorous lower pressure support trial. More to come on weaning because I think it deserves a more detailed discussion. So what we try to cover in this presentation is a number of basic things, introducing you to the servo-u and some of the concepts of what we're seeing in the management of COVID-19. Also, the use of high flow nasal cannula, and give you an idea of how we interact with the respiratory therapists in the ICU. Some of the things that we will discuss again, either individually or in a formal presentation, hopefully, is proning and when to prone and who to prone. At this point, I would say anyone that's significantly hypoxemic, the discussion should be had, despite whether they're focal or severe ARDS. We'll talk more about weaning for sure. We'll talk about epoprostenol, about ultrasound use. And then there's a lot of areas of controversy, including who and when to start steroids on in patients with ARDS, who to anticoagulate. There seems to be a lot of hypercoagulability, and a number of other topics I'm sure will come up. But with that, I'm going to end this presentation.